last time.
Sure.
I think
I'm really nervous.
I think we've actually already started.
Great. John, Richard, lovely to have you here.
Okay.
So today we have Richard Newsham-West with us, who is an Associate Professor at LaTrobe University, and he's currently the head of the physiotherapy school there. So to give some context for this conversation, Richard, do you want to introduce yourself, give us a bit of a brief summary and rundown of your clinical research background, and we'll go from there.
Yeah, thanks. So I started off as a physiotherapist because I was a track and field runner, middle distance and cross country, and started to spend a lot of time on my long runs and think about what my feet were doing, what my back was doing, and had a natural interest in the body and what was happening as you ran. And then had a number of injuries some of them were bad luck, a couple of fractured ankles, and then a couple of back injuries. One was from a car accident, and then the other one was from falling down an eroded bit of track.
This is what happens when you're running through the outback of New Zealand.
Yeah, that's exactly right. And not paying attention where you're going. And then through the process of rehabilitating and going to physios and seeing physios, and each seemed to have a different story and a different reason why. So I thought, right, I better go and find out. So I changed course, went from teachers college into physiotherapy. Oh. And trained as a physiotherapist, and then moved more into managing as a physiotherapist a lot of track and field athletes in New Zealand, and having again similar questions that I couldn't answer myself led me to do a PhD, and so a postgrad course first, and then a PhD. And still arrived now with many questions, some still unanswered. But I was fortunate enough to be able to start my career as a physio, as a sports physio, in the realm of the amateur athlete, which I think has been a blessing in disguise now when I look back, because I had a different type of athlete that you have now, who's a professional athlete, or someone who expects to be treated like a professional athlete.
Yeah, that's a topic on itself, isn't it?
It is, yeah. And I've noticed that there is a change in the attitude and the approach that these athletes have. Well, I think with the amateurs, there's a lot of people are very grateful to see a physio, very grateful to receive assistance and help. They've often parted money, so they've got some, I call it skin in the game, so to speak, so that they're actually going to do the exercises, whereas a lot of the professional athletes don't have that skin in the game, and therefore...
There's a sense of entitlement, isn't there?
There is a bit of that.
We've noticed that a lot in here, actually. We have a lot of team sport athletes that come through from different sports at times, particularly in off-seasons and those kind of things. And the difference between them and the track and field athletes typically we deal with, worlds apart. The track and field athletes are killing themselves to get better and to recover from an injury, whereas a lot of the team sport athletes are like, well, why am I not getting this for free? And it's very, very interesting. I think the professionalization of sport, particularly, and this is going to sound very critical, but I think it comes from my background of being in track where there isn't a lot of money, potentially when the athletes probably, I don't know, the word's not right to say earned, but the level of professionalism that they bring to their so-called professional sport doesn't actually match the time and effort being put in by people in, I would say, Olympic sports.
Yeah, absolutely. And I agree that I'd take it one step further and probably say there's a little bit in ownership of the pathology, or that is whatever they've got. The professional athlete relinquishes ownership and gives it to the medical staff.
They handball it really quickly.
Yeah, absolutely. And whereas the other guys have got ownership because they're willing to try and get it, as you say, they're really going to kill themselves to get better and get back into the sport. So I think there is this transfer of ownership is a big problem in the management.
Well, it's interesting because you would know Brady Green. We had him on one of our episodes, and it's interesting. He works at Essendon Football Club, and it's clear that, you know, when you've got a staff of 20 people who are in the performance and sports medicine team, it very quickly becomes them managing what the athlete's doing rather than the athlete being part of that involvement. And we asked them the question. I don't know that we probably got a really deep exploration of it, but to me, that almost seems a little bit the wrong way round. And in any times I've worked in those settings, it's become very much about the professional ego of that team and how well that they can put that below the needs of the athletes and even the team and the sport and the coaches and what they're trying to achieve in terms of performance. That's a weird balancing act for me, and I don't know that it always gets achieved in some of those settings. And you probably have some experience with that working in elite sport.
Yeah, I mean, I found it very difficult to differentiate between, because I've worked with individual athletes like track and field, which is you can grab hold of an individual approach to their management. Whereas with the team, it's the team.
Yep.
And what I've noticed, and perhaps it's just my naive impression, is that you actually move from the payer of the bills and the owner of the bills is the team, as opposed to the individual. And so therefore,
you're about that. About like where do you sit? Who's driving this bus? Because you're getting paid by the club to get a result for the club, not necessarily always for the athlete.
Yep, agree totally. And I think that's very similar to private practice versus hospital. The owner of the health system and the hospital is the Minister of Health.
Yeah.
And so they want bang for their bucks. And I think that's what happens with the team. We're paying this guy, we want him on the field. And I found that it becomes very policy driven.
Yes.
You've got this and very diagnostic driven in the sense that, you've got this pathology, therefore this protocol, we're going to follow this protocol because we've got to try and minimize the risk, which is not having them on the field, and maximize. Whereas the other way is, right, this is your injury, we've got X amount of time and we've got to get you better.
Do you think that that's a major problem in healthcare in general? Like, it's something that we've discussed at length. And I think we see it a lot more. I don't know if you've ever worked in North America, but a huge problem that they face, and there's been a heap of research on this, is that insurance companies drive healthcare more than clinical, outcomes or clinical management or expertise. And I think the similar thing happens in the sporting setting is we're reducing liability, right, and covering our asses rather than trying to maximize on the health outcome.
I agree, absolutely agree with that. And I saw the difference living in both here in Australia and in New Zealand. Okay. So in New Zealand, they have a thing called the ACC, Accident Compensation Act, which means that there is a no faults claim. So you can actually have an injury, but there's no suing or anything else like that. So there's no litigation around those injuries, and everyone pays a certain levy. Whereas here, everyone's fearful of being litigated against, and lawyers when I first moved to Australia, I couldn't get my head around why a lawyer was ringing me to talk about I was like, hang on, this is a bit weird.
I just find that so strange. Like, we do very little compensable work on purpose because I don't want to deal with that stuff. And I every now and then I'll get an email from someone who was in years ago, and the lawyer saying, "Oh, can we have your notes?" And I said, "No, you can't. It was 3 years ago. It's too long." And they get real pissed off with me, but I just don't care. I'm just like, you had your chance. It's done now. That we haven't seen that person for 3 years. Like, I don't know what's happened in that time.
Yeah, and I think what happens too, going back to your first question, I think what I've seen and observed is that as therapists, we become frightened. So we follow policies and protocols, and we follow a ACL protocol, for example, or we follow this protocol, or we follow what Brady's come up with, calf policy, and we're moving to population-based health, not individual health. And I think I lament a little bit when you look at the fact that you go up to, and I call it the demise of the randomized controlled trial, because when you start to see the randomized
book,
that's right.
that's the memoirs, isn't it?
Yes, that's right. Because I guess because I've been around long enough to actually have seen physiotherapy prior to the world of evidence-based medicine, which randomized controlled trials took over and confiscated the I call it the intelligent physiotherapist.
Well, we actually had this discussion in one of our recent discussions about this and how, like, it came in the 90s, David Sackett proposed this model. No one seems to know what he proposed. And we're saying how all of a sudden it turned into evidence-based medicine or evidence-based practice meant that 90% of what you do has to be backed by an RCT.
Yeah.
That's not what he proposed.
Yeah.
It was a third clinical practice and experience, a third patient values, and a third, like the evidence from the literature. Yet no one follows that.
Yeah, but it's held practice to ransom. Yeah, I agree.
I think too is an issue of, like, an RCT came around from the medical approach, which typically is pharmaceutical. And the great thing about an RCT, particularly if your main intervention is a pharmaceutical or drug, it's very easy to go, here's a drug or here's a placebo. It's very easy to blind the patient. It's very easy to blind the clinician. How much does that model actually apply to what we do? When you think about, there's so much more interaction between the patient and the therapist, and more often than not, you're going to be applying multiple interventions at once. Because there's a lot of assumptions that are made with a randomized controlled trial of, well, we're going to control everything so we can see the relationship between that independent variable. But then the question is, if you do a RCT for all these different interventions, does that then suggest that if you apply all these interventions at once, you're just going to simply get the sum of those individual parts as the outcome? Or are you going to see potentially a nonlinear outcome because of the interaction between those different interventions? And in fact, what we do know about human systems is it's more likely the latter, that as clinicians, when you address someone's problem, you're often identifying multiple issues and are going to apply multiple interventions because you're actually not worried about what necessarily works. You're worried about the outcome. What actual components have the most influence, or potentially how those components interact with each other, we may not actually know. And not to mention, if I apply a series of interventions to you versus John, there's going to be big differences based on the maturation of the system. So in terms of things like age, training history, their adaptability, not to mention like other factors like overall health and well-being that will determine how effective the system is at adapting to those interventions at the same time. So, yeah, it's something that I often think about is, do we need to think differently about how we approach research where the RCT does have pros, but it also has limitations? Do we need to be thinking differently about being more outcome focused with research versus intervention focused and seeing what the outcome is?
Yeah, that's a very loaded question.
Good.
Because I think there's a couple of things. The first thing is that, and I've always wondered, whether the randomized controlled trials, as you quite rightly pointed out, was to look, basically grew out of pharmacology and pharmacokinetics and all that sort of carry on.
Yes.
Does it, is the mathematics behind a randomized controlled trial wrong, or is randomized controlled trials wrong? So if we apply the linear mathematical models, a 0 or a 1 or somewhere in between, or should we be using the chaos theorem and then using sort of Bayesian type methodology, which actually starts to bring in that variability? Because I think you're right, and that how much of effect a simple thing of the placebo, how big an effect is that on something? And this is where I start to sort of, the more I read and the older I become, I start to question a lot of science. And I've just started to read a little bit now and got interested in the chronobiology, so the whole thing of circadian rhythms. And it goes, going back to the randomized controlled trial, is when do we measure the effect? Because if you look at, for example, for homeostasis in a tissue, there's the anabolic and catabolic cycles, and everything runs in cycles. Now, if you measure it at a different phase in that 24-hour circadian rhythm, you're going to get a different measurement. And so, therefore, if you measure it here, you might find more anabolic, but measure it here, more catabolic. But you measure it at this time, it's leveled out. So you say net change, 0. So I think that the randomized controlled trial has its place in informing and this is why I've always liked the phase or the phrase that we should have research-informed practice, not research-based practice, because then you end up missing, or you become protocol and you adopt things blindly. And I think the classic is Harkin Alfredson. He came out saying you've got to do heavy load eccentric for Achilles tendon. Well, his study, it worked for 40-year-olds. His population sample were middle-aged white men. Now, does that mean it's going to work for an 18-year-old sprinter? Probably not. Female sprinter? Could possibly not.
And part of that too is then being critical of the external validity in terms of looking at these specific criteria, because I think more often than not, there's a lot of extra criteria we should consider for patient populations. I was going to add one other thing though too. I think that's important to think about the complexity of humans and individuals. I don't think we should look at it as homeostasis. I think we should look at it as homodynamics. The reason being, stasis suggests that it's actually continuous. But if I measured, for instance, a particular hormone at the same time now versus in 6 months, there's likely going to be differences based on what you've done in that 6-month period. Have there been changes in your physical activity? Have there been changes in fat mass, muscle mass? Have there been changes in your diet? So there's all these extra elements that you need to consider too, because we're not looking at this like linear process of we know exactly what's going to, a good example is from a coaching perspective, the intervention that you apply now versus a year's time is going to be very different because their maturation and adaptability is going to change as well. But then this all brings to my mind straight away, do we actually learn these things clinically? Do we actually think about how the application of rehabilitating someone with Achilles tendinopathy but who's 20 years old and is a sprinter?
I think the point that you made was really relevant, is the difference between linearity and a Bayesian approach. The individualization of rehabilitation requires that constant updating of the information coming in, but we don't necessarily get taught to apply that kind of methodology. Yeah,
because we're stuck in I'm going to do this, and therefore I expect this outcome. And we do that with, I've always, my time tutoring and supervising postgraduates in the clinic, I've always said to the students that your outcome is never right or wrong. Now, it would be right or wrong if we look at it from a randomized controlled trial or experiential.
Based on your hypothesis.
Yeah, absolutely.
It doesn't,
But you have an outcome you didn't expect. Now, why is that? And I talk about the butterfly effect, and they talked about, a butterfly's wings creates a tornado on the other side of the world type thing. And I don't think we do that. But I take your point. You would expect, if I'm going to do this to a patient or do this to in a clinical setting, you would expect a change within 24 hours. That there's something going to change.
I always have this conversation with patients, and they often laugh at me because I say to them, the worst result is that you're exactly the same.
Yes.
I don't care if you're much better or you're much worse.
Yeah.
But if you're the same, I'm pissed off because it's like what I did nothing, or it hasn't created any appreciable change. So if they come in and they always get really annoyed with me and they say, "Oh, I was really, really sore and it made my symptoms worse." Oh, great. And they're like, why are you saying that's great? And I said, well, because we've got more information now. I understand the actual mechanical loading or whatever I've put in place has had an effect. It might have been, the magnitude might have been too high or the duration too long or volume or whatever it is, but I've actually got more information now, and that's helpful to me.
But that highlights to me straight away too. It's similar to what we were talking about before of this ultra-conservative approach that a lot of clinicians take, because, if you do have an exacerbation of symptoms, sure, it's not always ideal and context is everything, but more often than not, the process of getting better is not going to be this gradual.
No, of course not. But I think the big thing with that is communication.
Absolutely.
Explaining to the patient and taking them through the likely scenario of what it looks like, or even, I think I'm getting better at this slowly, which, I'm a slow learner, but asking them to actually maybe even outline how they envisage it's going to play out. Because I think the thing that I've seen as being probably the most beneficial to my practice when we started talking more about evidence-based medicine and looking at what the model actually proposed was actually respecting the patient values and expectations. And asking that question of like, what do you expect out of this physiotherapy input? or, you know, what are you hoping to get out of this, or what do you value? And I've had this conversation with people multiple times where you could clinically get the exact same outcome. You know, we've spoken about I've written a blog, I remember, about, like, say, knee surgery, post meniscus injury or something like that. If one person, they have the exact same outcome in terms of range of motion, you know, the pain level, all of those things, but one of those patients really wanted to run and the surgeon said to them beforehand nothing about whether they could or couldn't, and then they can't run, that person's really pissed off with their outcome compared to the person who just wanted to walk. And they're ecstatic that they can now walk without this catching pain in their knee. The outcomes are exactly the same. And if you haven't asked that question about, okay, what do you expect out of this intervention, you're not going to get an idea of what that actually means for the patient. I think that's sort of been really important for me.
And one thing that I've learned over my time, and I'm probably a bit of a slow learner too, is that people are not dumb.
Oh, no.
And so we
disrespect people, I think, a lot when it comes to this.
And
this stuff.
Sit down and explain to them. I've had long conversations about cell biology and biology and, you know, muscles and things like that. And what I've found is I've actually had a positive change in that a lot of my clients will go and read and come back to you with a whole lot of stuff saying, I've read this, what do you think? You know, and they're looking at this. And I think that's something that as physios we've got to realise, and I certainly realise as an academic tutor as well, is that I'm not the source of all knowledge. You know, the internet's got more knowledge than I can, but I've got to teach my client to become discerning, because gone are the days where you probably remember, you know, as seen on TV. You know, as if it was the gospel truth, if it was appeared on television. But people are saying, as the science says, you know, and so you've got to teach your client how to read that science and say, well, hang on, if you look at this, this doesn't fit what you've got because of these reasons. What I've found is that the client actually has well, I would say favourable, it's probably not the word I'm looking for, but a mind shift. And they actually start to participate in the
they're part of that process, and that's so much more powerful.
Isn't it? Yes, and these people that come in and they're engaged, they come back to you and say, "Look, you know, when I went home and I was really sore from what you did, but I found that I was able to lie this way and the pain went away." And you think, oh, "That's great. I'll do that." That's important.
Yeah. One thing, and this is going into a slightly different topic, but you mentioned explaining, say, cell biology or something like that, and it's a discussion that Jack and I have often. I know he's probably a lot more well-read than I am, but the basic sciences and the research in the basic sciences and how that informs clinical practice. I know that some of your research, you know, particularly looking at tendons, was looking at, okay, what's actually happening within that structure over time with different loading protocols. But that's not necessarily always clinically applicable. It's more looking at the basic function of that tendon, right? There is a crossover, I understand. You know, what do you see as... Do you see that the basic sciences are being used enough in understanding what's actually happening, and are we, you know, using that to our clinical benefit?
Yeah, the simple answer is no, we're not.
Yeah,
I think that cell biology or cells or science is not sexy, and you can't go and do it. You can't, like, you could learn a manipulation, you can learn a technique, go home and bring out a box of tools and go little tricks and do it. So I think physios have turned a blind eye to it. It worries me a little bit, because if the science isn't correct, we then apply it in a randomised controlled trial. So what's the purpose of doing the randomised controlled trial? I mean, you may as well randomise control against luck or good luck. I think that there's a balance, because I do think there was a long time we sat on the side of anatomy and science, and that drove us, and I think that drove more questions than it did answers. Then we went over the other side to the clinical implication of it.
Clinical,
and I was about going back to that. I think that it's interesting when you have a look at that. Prior to the randomised control era of the randomised control trial, we saw a lot of innovation. We saw Brian Mulligan's technique, Mackenzie's technique, Maitland's, if we're thinking in the musculoskeletal area. But after that,
and it's funny,
it's the force of these people that have applied the science to the patient in front, and then noticed something. Oh, that's interesting. I'll do it again. And you talk to Brian. Sorry, talk to Brian, and he's very open to the fact that his technique came out because he thought 2 + 1 = 3. I'll try it, and it didn't quite equal 3 the third patient. So he thought, I'll just modify this, and it came different. And so his theorem based
was it iterative in that sense of like he played and manipulated. With
and I always say to a lot of clinicians that your particularly at the postgrad, you don't get given a set of tools. That's it. You're actually going to go through a revolutionary change to become and evolve as a good clinician. Because if you don't modify, adapt, change based on your readings, then we'll all be just wiggly jiggling joints.
It's an issue. What issue? It's just a reality of it is a process. Like that's hence why we still have lots of questions that need answering.
With that in mind, do you see that we're giving clinicians, particularly, especially I think at the postgrad level, is probably where you start to come into your understanding enough, the actual license to take those small experimental steps and explore? Because I think that that's one of the things that I noticed, particularly with younger clinicians, they don't want to deviate too far away from the protocol, for instance, because they're almost scared of what that means if it's a bad outcome for the patient, even if it's for a short period of time. And they almost don't have the confidence clinically, which I find interesting, to take little small steps. And Jack and I always talk about this concept that came out of our looking at the work, the work of David Snowden and the Cavern framework. Jack and I always talk about, like, he always mentions the idea of, safe to fail experiments. And in our world, in this setting, we say to people, like, we're going to try this today in your rehab. I think that you're ready for this next step of, we're going to try this drop jump task or whatever it is, but you might pull up sore. Are you okay with that? Then typically patients are pretty happy to kind of explore with you if you bring them into that process. But I find that so many clinicians, especially that maybe don't have that license, like we try and give our staff, they would say, oh, well, it's only week 3. We can't try that yet. We're not at week 4 or week 5 when we're meant to be doing that, even though they've more than surpassed the clinical, findings to suggest they may be ready for a new challenge.
Yeah, that's a good question to unpack, because I think there's a number of things. I think there is a fear of litigation and fear of saying something and promising something. But that comes because the clinician's taken ownership of it. It goes back to my other comment. By empowering a patient, by giving them enough knowledge so that they can make an informed decision, you'll often find that they will suggest those innovations or those trials. I did this the other day and it didn't hurt. Great. Well, let's build on that. So I think there's that. I think that. This is only just a personal observation, so there's nothing to back it up. But when I went through physio school, which was a few years ago, the amount of knowledge that I had to learn is pittance compared to what they have to learn now.
In what sense?
Well, I think there's a lot more science. There's a lot more. I should go back there's a lot more content being taught in the physio program from when I started even teaching 20 years ago to now. And I look at the amount that we expect our students to learn, right from pain sciences through to everything else. I question whether we're cluttering the program.
Yeah, I was just going to ask you that question. Is that clinically beneficial?
Yeah, well, I think I go back to and this is my approach in the postgraduate era, and I think too, and I'm trying to infuse it within the current program, is that we've got to step back. And we've actually got to say we're not the source of all knowledge now. Gone are the days we used to write an article. I think my first article I wrote, it didn't get published for 3 years. So, there was that period of time where it had to go through and sent away. And so electronic journals now mean that processing and publications can occur a lot quicker. So I think that there is that process that, that the students are have access to a huge amount of knowledge. What we've got to do is actually don't worry about trying to teach all that knowledge, but we've got to teach them how to use that knowledge. And I think if we were to think about using the knowledge, we might get away from that scare or worried approach to, will I make them wrong? Will I make it? But I also think there is an element of, and I put my neck out here, that students come through a program where they've yes or no, they've passed, they've done the correct or not. Now, that correct treatment is done by my perception of what should be done. All right. They don't actually go and reassess the student 3 days later and go, oh, hang on, that patient got better. I wouldn't have done that, but they got better. So, but they've been marked here saying, oh, I wouldn't have done that. I would have probably done, but fail. So students are trying to gain a mark and not actually gain that knowledge and that experimental stuff.
We speak about this a lot because, the more understanding of, say, complexity, and people are trying to use these complexity models more. But the thing that I always find quite interesting is everyone gets really caught up on the inputs. And to me, that's not the important part. The emergent behavior is the important thing. So you could and the reason I think I'm probably more interested in that as a track coach, sometimes you put things in and what comes out, you don't expect at all, right? And you can, from a theoretical standpoint, what you applied is correct, or in your mind, from the understanding of, training theory and all those things. And what comes out is completely, not what you expect.
Yeah.
And so your only way to approach that really is to have a very close monitor on the emergent outcomes or the emergent behaviors, not the other way around. And as you said, we get so caught up in measuring what goes in.
Yeah.
We're probably much better off understanding what comes out and then almost reverse engineering that.
Yeah.
And that sounds like sort of what you're saying with
and you always push that reasoning. A lot of people finish their clinical reasoning at the treatment.
Yes.
The reasoning is the outcome from that intervention. And that's where and I always say this to the postgrads and even undergrads, your differential diagnosis is day 2.
Yeah.
When they come back, you're not now because, you can get the best guess, but you've got to look to see what comes on afterwards. And that will then marry it. And it goes back to, I think one of the key things that we've also lost in the program is the basic sciences, the fundamental sciences, so that you've got to teach the student to manipulate that in context to the patient we're seeing there. And
can you elaborate on that more? What do you mean by that?
I was just going to actually say, there's 2 things I wanted to say is, going back to your point, John, I think that's where we really emphasize and highlight this concept of safe to fail experiments, in the sense that if it doesn't work, it's not like the system's going to fail. It's more of you identify an impairment or a deficit that you may not see as being directly always related to their performance or improvement. Yet until you actually trial intervention to see if it improves, you might get a very unexpected surprise or outcome.
Yeah.
But I've lost my train of thought.
That's all right. It's because you interrupted, Richard.
Well, no, that's
your punishment.
Yeah. Well, I'll just sit here silently.
We were having a good conversation.
Shall I leave?
It doesn't work.
Yeah. Well, going back to the basic science element 2 is, I'm interested to hear your thoughts about how you approach this, Richard, because I feel like when you learn any basic science or theory, you need context. So if you just go into an anatomy lab and you see a cadaver that's being dissected and you identify origin insertion of muscles, is that an appropriate way to approach how you learn and information and integrate into your clinical reasoning? Do we need to be thinking a bit more about context of, here is a practical or clinical situation, this is the presenting condition, here is an understanding of the sciences behind, whether it be something around surface palpation, whether it's around understanding the muscle physiology and biomechanics. I'm interested to hear your thoughts of how do you think we integrate basic science into clinical reasoning and make sure that students or clinicians understand how to apply it to the real world?
Short answer is very poorly, if at all. Look, I think that I think your point's valid. I liken it to having children that have grew up with me and used to when we used to go on road trips, get the map out, the paper map out, and follow where we were going to go, and to now using a mobile device that they basically follow the little arrow and walk around. Now, you could say they're not using reading the map, the science of reading a map and getting coordinates and stuff like that, but yet they can still get from A to B probably quicker than I could by getting the map out. So it's the same thing. Do we teach anatomy and sciences in the old way, which I think we get stuck in, like let's have a cadaver and let's do these things. Whereas if you take it out of context and go, right, and keep it in context. So if I'm going to be palpating, there's surface anatomy and thinking about, so the student can go back to the anatomy, which could be, 3D spin things on anatomy on their laptop. So they can go back to using that as knowledge to inform what they're going to be doing. And so our basic sciences are, you're right, I don't know whether I'd use them as a case, but use them as part of your reasoning. So when a patient comes in and they've got a fat, swollen joint, the science behind why a joint might be fat and swollen, not inflammation has through 3 phases. The first phase is, that to me is very didactic, boring and plain, and people won't remember it. And I wonder if it goes back to that question that we've forgotten about it because it is so boring. Anatomy, the biceps has 2 heads and is innervated by this. Well, think about why from an evolutionary point of view, why do we have 3 heads or 2 heads of muscles? Why did the muscle bipennate versus this? Because it does this. It goes back to your thing about biomechanics. But don't talk biomechanics, when you're running and doing this and this. It's if someone does this and is unable to, what muscle could be doing, what muscle's going on? And it was one student just recently who couldn't get in their head about spinal stabilization. Now, that's another topic. But anyway, they were talking about the role of different muscles. And I said, well, whereabouts in front of or behind the spine? And is it a small muscle? Yes, it's a small muscle. So think about how's that going to create enough force to be able to make someone extend? Oh, right. So what sort of action is going to do? Well, it can only stabilise. Perfect. There we go.
Well, and to emphasise that point, that's why I find reading anatomy, physiology, pathophysiology quite interesting. Because let's say, for instance, anatomy is an example. It always amazes me how many students don't really understand the way that the abdominal muscles may stabilise the spine. But when you actually learn about the thoracolumbar fascia and you go, okay, we see this connection, but we also see that the erector spinae are involved, and we also see that QL is involved, and we also see that psoas major, iliopsoas, gluteals, latissimus. You start to think a lot more broadly about understanding a concept of lumbar stabilization. And I think the same applies when you think about, say, pathology. The more you learn about the basic concepts of, say, inflammation, it allows you to appreciate the differences you see in the inflammatory response of one person to the other. Because you may see two people who have, let's say, a relatively similar injury, they roll their ankle, one ankle blows up to 3 times the size of the other. And it's very interesting to start going, okay, well, why is there that difference? Sure, there's genetic factors, but, well, is there differences between patient A and patient B? Okay, well, patient A has a lot more muscle mass and a lot less fat mass. We know that those factors influence the inflammatory response and the immune system's response to injury. We know that patient A has been sleep deprived for the last week because they've had an increase in workload. So the more I've learned about basic sciences, the more I start to appreciate all the other factors associated with someone's presentation that influence their presenting condition. But I'm not sure, I question how often that's been effectively taught, because I know I've spoken to you recently about marking some crack exams, where do we want to think about what we think is the right answer, or do we want to think about how the student goes through their clinical reasoning process? And whether they do it differently to you, that shouldn't actually be the big emphasis, assuming that they're not doing something completely incorrect. But should there be more emphasis and appreciation put on them being able to explain the rationale for what they're doing, as opposed to well, I've got this injury, so, step one, this is what you do always.
Yeah. Yeah, absolutely agree. And I think where you described it as what we should be doing. I do have a little bit of a hesitation when you come to an undergrad because they're learning to walk, they're toddlers.
Yeah.
So there has to be a little bit of show and tell, but the right or wrong answer is only if you're saying, spelling a word or outlining a muscle.
Yes.
The origins of a muscle, the insertions of a muscle. That's right or wrong. And that to me is not demonstrating how people can manipulate that knowledge. And that's where, I've always said the way you ask a question in an exam should be about the manipulation of the knowledge, not the regurgitation of the knowledge. Then it doesn't matter if they cheat because, if they go and spend time looking on the internet, great. It means they're actually sourcing. They're learning, that's right. But you're questioning, teasing their things, and therefore there shouldn't actually be a right or wrong answer. You should actually be intelligent enough as an examiner to sit there and go, well, I wouldn't have thought that, but that's been justified in a persuasive argument based around the case that they've got in front of them or the patient they've got in front of them. So I think it's an evolutionary change that we need to take a student through. And I taught in postmodernism theories, they talk about knowledge deconstruction and reconstruction. And so that's what I think that we probably need to start doing, that a little bit more in testing the reconstruction, not testing the other stuff early on. But
that makes me think about the role of, say, clinical placements. And the thing that I really struggled with was a lot of the clinicians were not that interested in being a supervisor. And so their feedback was, you didn't do what I would do, so you're wrong. How do you think, and this goes back a long way, because if you look at the history of medicine even, it was, and particularly especially if you look at, say, surgery, it was by apprenticeship. We've used a similar model in the teaching of physiotherapy. It works to a certain extent, and there's obviously issues with it, which we don't need to get into. But do you think that overhang creates some of this stuff that you're talking about?
100%.
Yeah.
Because we're stuck on this, what they call entrustable professional activity. And can you do this, yes or no? I mean, that's a tick or, fail or not fail, instead of can you actually, it goes back to probably our very first comments, really. We're talking about being outcome focused, not input focused. And so can you actually treat a patient and get an outcome that's what I would call significant outcome? So significant meaning the patient feels like an improvement and you can measure a change in their function. To me, that's what we should be looking at. And early in a career or a program, we need to look at perhaps can you be able to manipulate a joint? Can you do that safely and effectively? Can you prescribe an exercise safely and with some level of accuracy? But can you now manipulate it and produce an outcome? And I think what we've got is this entrustable professional, almost like as you say, an apprenticeship. Can you do this? Yes, no. Which means it's very boring as a supervisor. Can the patient do this? Yeah. Or can the student do this? We have students that are chasing that yes or no, not chasing the ability to grow and be able to feel that they can do those little experiments, the one-off experiments, and see what's going on. And I think that's something at the end of a training program, more so probably in the postgraduate level, but in that early stage, towards the end, they should be able to do that. They should be able to, and one of the stories that always sticks in my mind was there was a fourth-year student at one of the previous universities that I worked at. And this person came in and had in-range cervical pain, so right at in-range, right rotation, say, for example. And they'd been doing grade 4 in a neutral position. And I said, why don't we just try and put them into right rotation as far as they can go and mobilise them again? But you might have to just treat resistance, so just touch on it and you might be grade 3 again, but give it a go and see how you go. Anyway, they cleared full rotation. And they said, where did you learn that trick? And it saddened me. I went, oh, dear, because they were looking for a trick. They hadn't learned that trick. And I thought, hang on, let's go back to your question. Here's the science of the supposed science of what a facet joint does. Here's the connective tissue sciences. This is what we did. Now, none of them individually may not be perfect. We may not know the full answer, but together they have an outcome.
I think the interesting part about that, we talk about principles a lot. And the thing that I find very interesting, and you may be able to elucidate why this happens more with your experience, but to me, I always find it very funny that it sounds so simplistic, but if a joint is stiff at end range, for lack of better terms, but is lacking, why would you not necessarily take it to that range and then try and mobilize it there? Like, to me, that makes perfect sense in the spine, as you said, in the cervical spine, in the knee, in the ankle. Yet a student is looking for, oh no, the protocol says I do these type of mobilizations in a neutral position. Why do you think that there is that almost silo effect of different segments and body parts? Is it the way we're teaching it, or is it because to Jack and I, we always have this discussion of, well, if a principle works on the knee, it's probably going to work on the spine. If it's a principle that actually stands the test.
I don't know. I don't think I've got an accurate answer for that. I would hypothesize that we probably goes back to, as a lecturer or as an academic, we teach knee mobilizations. We teach it in neutral. We get 15 minutes to show them. They get 15 minutes to practice when we're onto the ankle joint.
The question, sorry to interrupt you, the question I would ask is, do you think that the specialization, particularly in the medical field, drives some of this? That you have special, like, I
Even
find
in our field. So,
yeah, but I find I find it really weird that a surgeon might be a knee specialist. To me, if I was an orthopedic surgeon, I'd want to do everything, right? Maybe that's my megalomania kicking in, but I wouldn't want to do 700 knee surgeries a day. That would be so boring. And I would feel like clinically I would not be learning anything. I think they can justify it with the pay packet. But the thing that I don't understand is, why have they even evolved to be a knee specialist? Is it that the skills to do that are so specialized? Maybe this is arrogant to say, but I think as musculoskeletal practitioners, we don't necessarily, like, you might have areas that you're weaker, but I wouldn't say that for the majority of areas of the body, I'm pretty confident that I can give some clinical outcome that's beneficial to patients.
Well, I think particularly too, John, when you think about what are the most common type of presentations you see, like you and I always joke that we're both useless at identifying like risk injuries, because with the population
we don't see many of them.
We don't see many, but we're not concerned about that. We're happy to refer on to a hand therapist. But the reality is a lot of people will come in with non-specific back pain, non-specific neck pain, non-specific knee pain, or even if they say strain their hamstring. It's not necessarily always going about, well, what have they done? It's more about understanding why have they actually done it.
And those principles remain similar across those different segments.
Well, I think part of the issue, John, is, we've talked about this before, is I think within our learning, we need to be able to identify what type of a problem it is. So this goes back to some of the complexity theory of, are we dealing with an ordered or an unordered domain? So like a basic example would be if someone fell off their bike.
It's pretty obvious why they broke their arm.
And like,
it's called gravity.
And you can see clearly a fracture. You go, all right, this is pretty straightforward when it needs to be done. Go off to emergency.
Immobilize this.
Exactly.
RF or whatever it is.
But, the reality is most presentations that you see are more within the unordered domain. Yeah. So straight away, you're thinking, of course, you need to go through some assessment to go, does this need any particular medical or potentially surgical input? But once you've identified that, you quickly change into your thinking of
contributing factors.
Why did this happen? Yeah. Like, why is it that this happened to this person at this point in time? And then you go into that whole field of going, well, there's potentially several things. And more often than not, there are multiple factors at one point. But I mean, that's probably more getting to a postgraduate level, I think.
Yeah. I think going back to the medical model, I think that I did my PhD in the Department of Orthopaedic Surgery, so I hung around with orthopaedic surgeons for a bit, and I think it's more a case that they become proficient in an area, so they can actually do the operation a lot easier. They know the potential risks, and they can mitigate those pretty quickly.
Yeah.
So, a lot of shoulder surgeons can get in there, open up a shoulder and do the operation and not worry about and be in and out efficiently and effectively. So I think there's a bit of that. Knowing the orthopedic surgeons that I do know, that they do like a variety, and they will do a variety. And I take your point, they say the same thing. And if I have to do another jolly hip joint, I'll be
yeah.
But it's a bit like us. We see another sprained ankle, we'll probably go, oh, yeah, here we go.
Yeah.
But I think I can't. This is a cynic of me. I can't help but think that as physios, we wrap ourselves up in these areas of specialisation because we want to patch protect. We want to protect ourselves. And I always laugh when people say,
"What do you mean by protect?"
Oh well,
people, I actually know exactly what you mean. Like, people like to be the king of their little hill.
Okay.
Yeah, yeah,
and say, "Oh, I know everything about this."
Yeah, how dare you treat a shoulder? You're not a shoulder specialist. And you go, well, they're a simple joint. It's a very simple thing to do. And then you manage the people, and they come back and go, "Oh, I saw so and so," and they go, and then they ring you up and say, "Can you show us that trick?" And you go,
"There's no trick.
There's no trick at all." And I think that the funny story, may remain nameless, but there was a triathlete that I was treating, and they had pain. Shoulder pain, and it was during the catch phase of a swim section, and it was always towards the end. And this person came in, so I had a look at him and bent, twisted him, and had an examination of it. But then when I looked at it, it was I think it might have been mid-thoracic, somewhere in the mid-thoracic, was very stiff. So when he was up there, you could see it sort of not moving very well. So, I got in there and gave it a wiggle and got it. I think I ended up manipulating it. Said, "Right, I go and jump in the pool and do your training." Came back the next day and said, "Doc, I've done 2 swims, no pain." And so then the physio rang me and says, "How dare you treat the shoulder? I mean, you're not a shoulder specialist. We employed you because you're a lower limb specialist." And I'm, "Well, I'm not even that."
Well, and to play devil's advocate, then people might be going, "Well, why are you doing manipulation? There's no evidence for that anyway."
Well, there is evidence because the patient got better.
Yeah. But this is, I'm obviously being facetious.
Yeah, absolutely.
Part of the issue here is, well, what do you mean by that? Because clinically, it works.
Yeah.
Isn't that the most relevant thing in this situation?
And I think that's what as a profession, we've thrown away these things. And I worry a little bit because, manual therapy is being thrown out the door because we're all into strengthening or into sitting down and talking about people. When really,
it's really disappointing. I know that there's a physio that I learned a lot of when I was an undergraduate student. He was involved with the football club that I was working at. He was formerly the Collingwood Football Club physio. Awesome guy, amazing manipulative therapist, and just taught me so many different techniques for manual therapy. And I just had such respect for the way in which he approached it. And I think physios of your era are very, very strong there. Physios of our era, and particularly younger, are terrible at their manual therapy. And I think it's so dangerous because working in sport particularly, and you would know this with your time in athletics, if you can't make a change there and then for an athlete, they will disregard you straight away. And because for them, if they're on the start line in half an hour and their ankle's sore or their Achilles is hurting and you can't do anything for them, you may as well be completely useless to them. Which to me, I think you see these dumb arguments, particularly on Twitter, which I got to stay off there at times from certain people, and some people will know who I'm talking about, who say manual therapy is useless.
Yeah.
And the first thing that comes to my mind is, well, you've clearly never worked in elite sport, because every single, and whether it's placebo, it doesn't really matter, but the athlete is looking for some sort of response in a very acute, transient setting to be able to get up for their performance. And if you can't make those changes, then you're actually giving up skills that are going to be beneficial to that individual.
Yeah.
Why are you lumping manual therapy as one whole thing? Like that's kind of, to me, I look at that as saying, if you had a sprinter who came with a hamstring strain and all you gave them was walking and you said it didn't work, exercise is useless. Hang on a second. Manual therapy
is much more broad than
there's so many different types.
There's
so many different intensities. There's so many different configuration variables.
You've hit the nail on the head. I think that's what we've done is we've lost the art of manual therapy. And manual therapy is everything. I mean, what's the guy Hunter talked about specific mobilizations of tendons, and one paper, 2 papers later, no one talks about it because it doesn't work to everyone. You can't just mobilise. And you've probably seen this in younger physios. They go and do a Mulligan course, and everyone gets treated with a mobilisation with movement, and they get 60% of them have a response. The rest, well, that's a waste of time. Well, now they're going to go off and do dry needling. So they go off.
All you got is a hammer. Everything looks like a nail.
Yes, that's right. And I think that I take your point because a number of times you've had an athlete lined up with a team that I've been physioing with, a track and field, but they're in spikes, they're in minimus shoes, they've got a sore navicular. It's not just I'm going to wiggle and jiggle that joint. I'm going to actually put a sling. Now I can't don't want to put a Lodi because that's going to affect everything, but I could put a little sling because when I push the navicular or lift the navicular, or whatever you want to call it, glide it in a dorsal manner, the patient can actually do a calf raise without any pain. Why is that? Well, let's put a sling on there with a bit of tape. Oh, there we go. Right, where you go, run the race.
Get through the race, and then you can worry about it after.
Yeah, why is it there? Absolutely. And I think that we forget about the subtleties of whatever we put in. And there's so much I call it a poke and hope technique. It's you've got amplitude, you've got frequency, you've got velocity, you've got all sorts of things that we don't think about it. So it goes back to our basic science. If you don't know the basic science of connective tissue, you can jump up and down on a joint and not get any change. But if you're thinking about the thixotropic effect of connective tissue, you're going to glide in there and get the creep or get the change you want.
I want to ask you this because we spoke about this in a discussion that we did on flexibility. And as you know, that's an area that Jack's really interested in.
You're kidding. You ready? I don't think.
And we spoke, to the physiology of what's happening in the tissue when you do stretch and the different amplitude and magnitude and duration of stretching. The same thing happens, and I know Jack brought it up in one of the discussions we had about manual therapy. Why do you think this is, not well known or widely spread? Because if you say these kind of things, they talk and people look at you as if you're talking witchcraft.
Yeah, they do.
Which I find interesting because, as you said, there actually are papers that support that there are physiological changes happening at a tissue level with input of mechanical, whatever mechanical input you're creating through manual therapy. That's
right. And we forget that, part of the principles for doing an exercise or a loading protocol is to change the mechanobiology. Yeah. That's all it is putting a load, and we're doing the same with our hands.
So why do you think it's sort of poo-pooed these days? But the evidence is there, or at least the start of the discussion is there in the literature.
Actually, it makes me think, Richard, I remember you telling me a story about you presenting at a conference related to the amount of publications of theoretical versus applied studies. I think that's probably a good analogy. John's question.
Yeah, I think that we've gone to this randomized controlled trial era where it's black or white, there's yes or no, probability of we've lost the art. And to me, physiotherapy is the art. Yep. It's the art of sciences. And that goes back to that comment you just said, prior to the randomising, there were the artists, there was the Maitlands, there were who were trying things. They didn't actually have the good sciences, but they had, but then the sciences came along and disproved it. Now, it disproved it through that lens, not through
the outcome.
Not going, well, hang on, it's still got better, but if we look at it through that way, it didn't get better. We've got no evidence to support it. So is there another methodology or another method that's creating that change? And instead of going, let's have another look at it, then we just dismiss it. And I always talk about having taught at postgraduate level the Mulligan technique with Brian Mulligan himself. And one thing that you'll see me do a lot now is I noticed with Brian, he said A, but he did A plus B. And I remember asking him one day, and he said, oh, yeah, I just do that automatically. And it's, he does a mobilisation with movement, for example, and it's not just a linear PA But if he pushes that way and the person moves and it almost gets a bit of movement, but not, he'll just change it slightly, and he might move the force vector slightly, 4 or 5 degrees. But he does that without thinking, because he's feeling the resistance and feeling what happens. And then the patient turns and goes, "Oh, the pain's gone," and he does it. And people go, "Well, it's not working on me." Yeah. So I think, and it's the same with Maitland. We threw Maitland out with the bathwater. And if you actually read his books, and actually I've been fortunate enough to watch one of his old black and white, a film of him teaching, and he does that A plus B,
there's
minus the variable C, and he gets D, and you think that's the artist. And I think that's, as physios, I go back to we've got a group or generation of physios that are chasing the entrustable professional activities. Have I got it? Have I, yes or wrong? Students coming through, what do I do to pass? They do it. They don't actually learn that artistry, and that's what I've, over the number of years, of 20-odd years, trying to install in the postgraduate area, that it's actually this artistry, feel, listen, manipulate, change, and you be open to a result that you may not have expected. And that's where the fun begins, because you can go back and go, go and read a book on this, go and read a book on that, start to read about why that might be, and let your body go all over the place. And they say that there's I cannot remember I was trying to remember on the way over here, there's a term in the French which basically translates to being a handyman.
Jack of all trades.
No, not a jack of all trades, master of none, but more being the handyman, who has knowledge in plumbing, plastering, bricklaying, all these things.
Yeah.
Brings them together and can do a really good job, because he's the artistry of that. And I think that's what clinical reasoning needs to be. Bring some stuff around evolution. For example, the glutes, for example, don't just extend the hip; they control forward inclination when the ground hits the ground, of the trunk, to absorb energy. It's a big spring, So therefore, if you've got a runner, you're not going to train the glutes to do hip extension. You've got to think this, or you're thinking about biological systems, and you think about this chronobiology. So there's some evidence to show that people that work shift work have higher incidence of low back pain and stuff like that. And there's some stuff just recently in the last 2 years that have shown that there's this mismatch between circadian rhythms and sleep and awake cycles that actually makes them more prone to back injury, because it changes the whole inflammatory process within the body. So whilst we talk about sleep being important, we now understand that there's this part of it. Does that mean that as an athlete, should we be training our athletes at a time of the day that's actually going to maximise or benefit that?
It's interesting, because this discussion makes me think very much. I'm signed up to go to the women's sport conference that I think LaTrobe's running.
Yep.
Through a coaching program that I'm involved in. And one of the topics, I coach a number of top female athletes, is around menstruation and what you do with that. And I really struggle with this concept of manipulating training around menstruation, right? Or competition. For the simple reason that you don't get to choose when the competition is. Obviously, you may want to manage maybe their symptoms or what they're doing around that. But I think it's similar to this, where a lot of athletes I hear, and even some of my athletes, they whinge particularly about the weather, right, in Melbourne. And they always complain that we've been doing a few trips to Queensland recently, and they're saying, it would be better if we were just here all the time. And I actually say to them, I actually would hate that. I think that would be bad. And they're like, why do you say that? It's because what ends up happening is that you're always working to, say, the perfect scenario. And that's not what happens when you go to major championships. It's not what happens when you go to, even this year, for instance, as an example, our national championships were in Sydney. It was pissing rain and it was cold the whole time.
That's right.
So if you're in WA, you're in Queensland, where it never gets under 25 degrees, you think that you're about to die when you step on the start line in 100 meters. Whereas my guys that whole week had been pissing rain here, and they were like, well, this is like 3 days ago when I was doing my last major session. And I think that, to me, from a practical standpoint, makes me think about that chronobiology stuff of like,
Yeah.
what's the benefit of doing, are you getting more adaptation by working in that perfected time, or are you getting more adaptation by actually putting them at a disadvantage? I've never quite been able to work out where that sits. And I had this, I'm going on lots of tangents here, but I had this discussion with someone who was doing their strength and conditioning hours at the moment with us, and we're doing some squats and we're working out people's peak power and where it occurred. And then he said, okay, well, would you then do your training at the weight that produced the peak power? And I said, well, it depends on what we're working on. Do we want to work on the velocity side? Do we want to work on the strength side? We might go above or below that number. And I think the same thing with, if the prime time to train is 10 o'clock in the morning, do you always train at 10 o'clock in the morning? Because that's going to be, are you going to get more adaptation from that? Or are you going to get more adaptation from actually throwing them into disadvantaged scenarios?
Look, I hear what you're saying. And rightly or wrongly, the way I've rationalised it, because I've had the same working with athletes and being an athlete. I wouldn't say I was elite, but I was,
I think you're downplaying that from what I've heard.
I think there's a spectrum, and I think that what we're trying to do in the early phase of rehabilitation, we've got a deficit in the system somewhere because of a pathology or damage or whatever we want to talk. I always say during that phase, we've got to optimize the adaptation. So in recovery, you may want to look at the time and the circadian rhythms and when we actually get maximum adaptation. So there's some evidence to show that endurance-based type things occur more around that sort of mid-morning, late morning. So we may want to do that. But I do take your point, and Peter Blanche and I have always had a big chat about this, and we both feel, we call it the cotton wool phenomenon that we see. Don't do that. Let's put some cotton wool around that athlete, and don't. Where there's an economist who wrote a book, Black Swan series, and I can't remember.
Nassim Taleb.
And talked about the robustness in the system. And I think what you were just talking is getting that robustness. So you've got to push the boundaries to create enough robustness within that system that you can line up. I mean, I've run races where you couldn't see from me to your way because it's snowing, and that's because I raced in New Zealand. But equally, I've done other races where I've started off in beautiful sunshine and a singlet, but finished in blizzard conditions. Now, the robustness in the system, whether it's the psychosocial aspect or your brain and a lot of that stuff around Endure, who was the guy that wrote the book, about the drive of the upper 2 inches, or as Peter, that's where Arthur Lydiard used to say, or it's the robustness within the muscle physiology or the joints or whatever it is. We've got to train that. You've got to be able to.
That's something we spoke about with Brady, and I said to him, and this is probably in my mind a bit of a post hoc analysis of what we spoke about. But I, from what he said, and it's a very limited view, I feel like they've cotton wooled their players too much because they create a nice scenario for them too often, rather than actually, or not putting them through hell, but putting them through unexpected and uncertain situations in their training environment and making it, it needs to obviously be realistic, but you need to put them into scenarios that are difficult to drive adaptive potential. I think that's something that we don't necessarily discuss as physios in the world of exercise prescription is, we can get a good outcome by doing these more, perfect scenario of adaptation. But are we building that broader branch of robustness by really starting to push what the envelope could be?
And changing what Jack says, the different variables of lifting a bag of flour, for example. And I agree totally. And I think that what we do is, and this is probably one of the reasons I stepped out of professional sports, because I was found that I was being dictated by this exercise scientist. They're saying, this guy's got to run so much, he does X amount of impact as this, so we want to train that. And I was saying, but that's not why I got injured. It's and I always thought back to, there was one chap I remember treating when I was in New Zealand, and he was a rugby player, hard guy that didn't no brains and all brawn type almost, and he hurt his shoulder in a tackle, and said that we rehabilitated and everything else. Now this was the era of the not professionals but the amateur. Now I said we've got to get it stronger to be able to tackle, and he goes, yeah, fine, yeah, okay, I'll do that. So he was working on the farm, throwing hay bales and sheep and then cattle and things around. Got his shoulder really strong, but then he said, I now needed to start to build that level of robustness into his shoulder. And he came to me one day and he said, I think I've worked out how we can do it. And he had gone into the rugby shed and he had got some boxing bags and he hung them up across the top of there. And he said, I want you to randomly throw one of these at me and I'm going to tackle them. And I thought, this is weird. But anyway, and I thought, I can understand why. And so he came back to me saying that he needed to be able to tackle a bag coming from any direction, unpredictability.
Yeah.
And that's when I started thinking, had I just done what the physio done, just done external rotation and done some very simple linear weights training, he wouldn't have been robust enough.
No. And I think that unpredictability of that situation, and that's what rugby brings to you.
Yeah, but even track and field, all my track and field athletes now, I rightly or wrongly, but I make them run around mountain tracks.
Yeah, I was going to say, yeah, because taking them off the surface will actually create a lot more robustness.
Because they've got changing directions, they've got going downhill and then uphill, and that whole...
It's really important.
Yeah, I agree totally.
It's also reflective of their mindset. And I think that's where I know John and I have talked about this before, of the difference between robustness versus anti-fragility, which is something that Taleb talks about. Because you don't want actually that neutrality in their response to the stimulus. You want them to actually positively adapt to each stimulus that you apply. Part of that, though, also comes with the mindset of actually being willing to accept those challenges, because that's going to influence that physiological response. And
we've spoken about this before, but, any hormetic response, the first outcome is usually negative.
Yes.
They're really sore, or, their performance goes down in the short term. Even from a training intervention, you train hard until you have a period of recovery and consolidation. You're not going to get the beneficial outcome. So, as I said, that psychological component of being willing to accept that period of discomfort, whether it's psychological because your performance has gone down, or actually you're sore or whatever it is, that's the hard part to kind of probably get across.
That's right. And that's that homeostasis.
Yeah.
Homeostasis is static.
Yeah.
That's the thing. Yeah.
We're any athlete.
On that,
yeah, that's right. Homeostasis means you only run a 4-minute mile. You never go faster.
Well, and the magnitude of the stimulus you need for adaptation is going to change too. Because what's going to create change now is going to be different in a month, 6 months, 12 months time.
And that's where it goes back to that sliding scale. There was a guy who wrote called the specific adaptation to imposed demands. And you tickle a cell to start with. If you thump a cell that's fragile, it's just going to die. So you tickle it, and then you've got to thump it to get it to change. So that's the same. We're all made of cells, so it's the same. If you want to train for a marathon, you don't go and do a small 2 laps of a field. You've got to go out and.
I wanted to ask you, and this is slightly going off topic, but I think it's related. Is clearly your expertise in track and field, a lot of it probably was influenced heavily by your involvement in the sport. And I've always had this theory that if you want to be a good clinician in working in a sporting setting, you don't have to have been elite, but you have to have done that sport to some reasonable level to understand it. Otherwise, you're so far behind the 8 ball, it's not funny. Do you carry a similar view, or is that, am I now probably being, controversial because people would say, well, I'm a really good therapist and I didn't do the sport? I think it's the same in coaching too, for instance. Like I give the example, I don't think you have to have been really good, but I think you have had to have done the sport at a reasonable level, or at least participated regularly enough to understand what it entails.
I know when Brady tried out for Essendon Football Club, one of the tests that they did is they took him down to the footy field and kicked the ball with him.
Yeah, well, and he played football at a high level. He played,
and he's a good football player.
Back then it was TAC Cup, but NAB. NAB League now, he was a pretty good high-level footballer. It was close to playing, say, VFL level. So for him, it's not a new environment. And he spoke about this in our discussion of, him being able to go out on the field and kick balls with them and do certain things and understand, okay, well, I've got to position myself here and do this, actually helps how I help rehabilitate them.
Understand the specificity of stresses needed for rehabilitation of performance, absolutely.
See, I'd be probably a little controversial and say no. Yeah. That's patch protection.
It's not controversial. I think you're in the majority.
And I would argue because, a good coach is always a good coach. And, I think of, one of probably the classic, a strong example that I had growing up was my father, who was a rugby player and went in and was a good coach for rugby. But then when I was in between coaches, he coached me, and I had the greatest amount of improvement in me as an athlete under his mentorship.
That's more that he was a good coach already?
Yes, I think that's right. He was a coach. He wasn't I think that as a physio, I'll go back. I think a good sports physio is someone who's been involved in sports.
Yeah.
I think a good sports physio is someone that is willing and open and is very observant, because I think that we've all got the skills to be able to pick up. But I also think that as a good sports physio, you've got to be willing enough to say to the patient, what do you need to do this? And how do you actually do this? I mean, I played rugby until I was, so small and skinny that the only position that was left for me was left right out. And so I've never really played, but yet I physioed for representative rugby teams and union teams, and I can treat props, low backs and shoulders because I'm observing, and I can observe, and I always ask the prop, what is it that you have to do? What do you have to, what sort of stresses are involved in that? So I think there's a little bit of patch protection to say that you can't do it unless you've been that. But I also recognise the fact that that knowledge grows. I mean, when I physioed for hockey, I'd never played hockey in my life before. But after a couple of seasons, you knew that knowledge.
Do you think it's just a time thing? Like, you pick things up, if you've got the background, you can pick it up quicker. But if you've got those skills, you can eventually get there.
I think, and if you have the skills that we've talked about, I think you can. But if you start to say, I'm only doing feet and ankles, then you won't be able to be a physio anywhere. I mean, I think that having the broader look and the broader view on what basic sciences, mechanics, tissue sciences are telling us, we can
transfer that knowledge to different domains.
To a lot of things. I mean, I often get a wee bit upset when people say, well, you can only treat a shoulder if you've done these courses. Really?
That's true. Well, it goes back to the point John made before about thinking about universal principles too. Out of interest though, because you competed at a pretty high level in distance running, do you feel like that had an influence on how you approach treating runners yourself?
Both positive and negative. I think sometimes the negative biases can influence it.
Because you think that one approach is going to apply to them? Or?
Well, yeah, sometimes you put your cap on and you say, well, especially if you have a certain philosophy around how you think.
You're talking from personal experiences?
Yeah. Yeah, well, it's not the only thing I can speak from.
Yeah.
I would say is, like, if you have a personal philosophy around, I know I get myself into a lot of trouble when I get a lot of sprint athletes come and see me, right? Because I coach and I'm physio, and people come and see me often for hamstring injuries and all those kind of things. And I have a very strong bias to how I think you should prepare sprint athletes. Now, it's broad, and there's room for a lot of changes in how you would do that. But if you, for instance, and it's exactly the point you bring back to the SAID principle, specific adaptation to imposed demand. If someone spends their whole preseason jogging and then in the transition phase from lower intensity to high intensity does their hamstring, I'm really critical of the programming, right? And that's a broad example, and you don't see that as much now, which is kind of nice. But my bias means that straight away I'm pointing the finger at the coach rather than actually probably looking at the contributing factors with less bias.
Actually, this is a question I want to ask you, John. It came up when we were talking about distance running the other day. Because I know you obviously do mainly short, long sprints, 1 to 4, but you've had a couple of middle distance athletes. Did you find that there was learning curves that you had to change with how you approach those middle distance athletes in terms of the amount of anaerobic versus aerobic training?
Yes, and I think luckily for me, the athletes, it's exactly kind of probably what Richard mentioned of asking them and being willing to learn from them and not being like, well, I know because I haven't coached this event. You know, I was lucky enough with the athlete that I had for a while. We kind of developed together and he was okay with that. Because I'd say to him, you know, this is what I'm thinking of as a session, or this is the next training block. Do you actually think this is appropriate? And at times he'd be like, oh, that sounds a bit crazy. And other times he'd be like, no, that's okay. Or maybe I can do more than what you're actually even proposing here. And that seemed to probably work almost more so. And I think, you know, the more I think about it now from what Richard said, he's probably swayed my thinking even just within this chat about like, potentially sometimes it's a negative, the biases that you have around having that previous experience.
Yeah. Well, I know it's interesting talking to you because you've had a fair bit of experience with hockey in terms of helping out, but you haven't played yourself. But it seems like you've developed a pretty good understanding of the needs analysis of hockey.
Yeah, I would say the reason that I say, and I take the position of like there would be benefit in playing the sport, is it probably took me 5 years.
Yeah, okay.
And maybe that's laziness on my part. Because I don't necessarily find the sport specifically that interesting, right? So I probably didn't rush that learning curve.
Yeah, I think you're right. And I've been fortunate enough to work when I was with hockey with a really good coach.
That helps a lot. Yeah, they educate you as they go.
Yeah, but I was educating them.
Yeah,
and so I'd be saying X, Y, and Z, and he'd go, "Well, you can't do this. You've got to do this." You go, "Well, I'll modify my thought process." And I think you do bring a lot of bias, and whether it's your social belief, whether it's everything else you bring into that space. And going back to your question, I think initially I brought a lot of my belief and why did I used to do this, why can't you? But I guess because I've always been a person that, and perhaps I didn't grow up, I was always asking why. So even when I was doing my 20-mile runs, you do a lot of thinking in 20 miles. And I used to say, why? Why did this?
Why are you running 20 miles?
Especially when you ran past the bakery. Why am I doing this? I could be eating a hot pie or something. But yeah, I think that you've got to question yourself. And I think that's what makes a really good sports physio, is questioning your beliefs and your principles. Why am I doing this? Why am I doing that? And a nice example of that was, when I was with the track and field, as you know, often when they transition onto the tartan track, you start to get a lot of blisters.
You see things coming up. Yeah.
And you start to see these blisters coming. And I'm thinking, how am I going to treat this? What am I going to do with these things? And that's when, I started thinking very laterally and went, I need something it's going to help the blister heal. It's not going to be aqueous and wash away and get stuck in the socks, and have an anaesthetic. And that's when I started treating blisters with hemorrhoid cream, because that's what you want. It's got everything in there. And so I started questioning that sort of process. Whereas, I was sitting beside a podiatrist and he would say, put some orthotics in, put some this. And I go, well, no, it's not going to change it. And so questioning and then I was always taught as a physio, you need to put low-dye taping to create another skin. And I'm going, that doesn't quite fit. So I think you're always questioning your knowledge as questioning your beliefs. I go back to the blister story, was that I had a coach that used to say when you got a blister in middle distance, of course it was often because the shoes weren't fitting properly, but he would make you wash it in methylated spirits. And it hurts for a bit. It hurts for a long time, actually. But it was, and I think, what am I trying to do with that? What is the purpose? And it goes back to, again, some of the things we've talked about. When I'm mobilizing a joint, what's the purpose of doing it? Why am I doing this? Am I going to modify this? Or am I just going to... So I think that's the whole thing about thinking laterally and questioning, and the ability to formulate an answer based on being a wide reader and reading a variety of texts.
I think interesting, like I always say this, that coaching has been the biggest educator for me in that being willing to be self-aware, because you get your ass kicked a lot. You think it's going to lead to this outcome and it doesn't. And that's, we spoke about going to, exploring the outcome, but it's exactly, I think what you're saying is your experience tells you that if they're getting these blisters, the outcome that I want is this, and I've tried all of these things and they're not working. So it doesn't matter whether theoretically they're the best. My experience is coming into this and saying I need to try something different. Yeah. And having those experiences does make you, as you said, evaluate whether you're actually willing to change your belief around a certain area, because ultimately the outcome for both, whether it be an athlete or a patient, is about them, not about you.
Yeah. I used to do a trick with the postgrad students. I used to give them once they assess the patient, they'd say, I'm going to do this. And I say, right, there's a golf ball and there's a piece of tape. You can only use that to treat them. And made them think.
Yeah.
What is the purpose of what you want to do? How can you use those two materials to get an effect?
We can create constraints, yeah.
And so they had to think laterally. And the reason I did that was during my time when I was doing adventure sports and physioing for those. And often you're in the middle of the bush and you've got an athlete you've got to try and get, the next 10 Ks running across country. And you got this little tent and you got a bag of tricks or a bag of, tape and a bit of massage oil and some other stuff, and you've got to try and get them. And, I've gone out and broken branches off a tree and taped them to a person's to be able to get
way more interesting stuff.
Because I wanted to immobilize a finger so that they could get on the bike and bike down the road. I knew it was broken. I mean, there's no question about the brake. But could I put them in an ambulance and send them off and they'd essentially finish their race? Or do I use some branches and put a splint on with some physio tape and they can continue the race because they had to just sit on a bike? Well, they're not going to use their finger to cycle. And so, I had to immobilize fracture principles.
All right. We're about to tick up to an hour and a half. So I think we might thank Richard for his time.
We'll have to get you on again at some point.
Yeah.
More than happy. It's been great.
Yeah, it's been a good conversation.
Very good. Very lateral.
Yeah.